Good morning, everyone. Good morning.
Could do better than that.
Welcome to this fireside chat. I have to say, it seems a bit odd to be having a fireside chat when it's about 80 degrees and 80% humidity, but there you go. It's really a great honor for me to introduce Dr. Francis Collins, who's the director of the National Institutes of Health, to be our speaker or chatter today. And it's a particular honor, of course, because I actually worked with Francis for a number of years. And many of you were here last evening, and I won't try and repeat the wonderful words that Rick Shannon used to describe Francis and his long history of science. But it's just fair to say that Francis is definitely one of the world's leading scientists. And I have to say his work on the Human Genome Project, before that work on particularly gene loci that related to disease, cystic fibrosis, Huntington's disease, were actually fundamental developments in healthcare. And now, of course, for the last 8 or 9 years, he's led the National Institutes of Health. And that's been, my 3 years of observation there was just really quite eye-opening, coming from being a researcher to actually be part of the leadership and seeing what transpires every day with Francis at the interface between the executive branch and Congress and all of us as scientists. We are extremely lucky to have him in that position. I'd also add on a personal note that working with him for 3 years was an absolute delight, and I learned an enormous amount. So thank you very much for coming, Francis, and it's just an honor to have you here.
Well, Phil, if I may, it's a joy to be here and to be back at my alma mater and to be hosted by you. And the contributions you made to us over those 3 years as the Associate Director for Data Science, really getting NIH out of where we had been, which was behind the times, into something much more forward-looking and positive. And I know we're going to talk about that. Was a great gift that you gave to all of us. And we mourned it when the University of Virginia figured out how to lure you down Route 29 to Charlottesville. But now having the chance to see what you and others are building here, it's truly exciting to see how the University of Virginia is on this rising curve in data science, in neuroscience, in a wide variety of other areas. It's wonderful to see an institution that I care so deeply about finding itself into this remarkable moment of opportunity. So it's a pleasure to be here, and thanks for the chance to spend a little time with you.
Thank you. It is, in my 5 months here, come to realize it's an absolute wonderful place. And it's wonderful colleagues that I have working with us here, and it's just really enjoyable. The theme of, and we can drift a little on this theme, but the real theme is the notion of where data science and analytics fit into the future of biomedical research and healthcare. And we're going to have a little chat about that, and then the idea is to open up the floor to various questions about that. So I was going to ask you, just to get the ball rolling, to sort of look backwards with respect to how open data and sharing and analytics have played into particularly your own work, and then your leading of the Human Genome Project. Because my sort of feeling about it all as a computational biologist was I wouldn't be here and I wouldn't be doing this if it wasn't for the Human Genome Project, because I think that was what really sort of precipitated this use and the desire to have open data. So I'm wondering whether you could sort of comment on that history and sort of give us some insight.
Dr. Collins, thank you. You made the statement that these large-scale open data sets empower researchers. I would just like to paraphrase that, that these opportunities for establishing these large-scale genetic databases empower patients. And the question that I want to ask you is that we're moving quickly towards very large-scale sequencing. And right now, there is unprecedented opportunity for rare disease patient organizations to establish their own exome banks, which empowers them to attract researchers in what they view as their patient interests. What I wanted to ask you was simply a technical question. exome banks provide the properly comprehensive genetic material for very profound research to be done, or should we wait for large-scale access to genome sequencing?
That's a great question. I think what you said is absolutely right, and I should have been more clear that these large-scale projects are not just beneficial to researchers, but also to patients who are anxious for having this technology reveal answers to questions that might otherwise get neglected, because rare diseases oftentimes have a hard time finding a cohort of investigators that want to work on their problem. But I think you've seen quite a dramatic step forward in that regard. Oftentimes when exome sequencing does get done on a particular rare disease and you find the answer in terms of a missense or a nonsense or a frame shift mutation occurring in multiple individuals, it lands you in a pathway, and that links you up with investigators who are working on that pathway who had no idea that their research might be relevant to this particular rare disease. And I've seen this happen over and over again, where those groups then come together fairly quickly to the great benefit of all. It doesn't always happen. Of course, the exome sequencing for some rare diseases has not immediately produced answers. My own research lab at NIH is engaged in a effort to try to uncover the cause of a particular kind of hereditary facial palsy called Mobius syndrome. And we've generated a ton of exome sequences and still aren't quite sure what we're looking at because it's so heterogeneous in terms of the findings. And at least in one instance, what was a sort of a bust when it came to exome sequencing has revealed itself by going on to whole genome sequencing and finding out there was something more complicated. I don't know that's going to happen very often. I would say for the most part, rare diseases are doing pretty well by the exome sequencing strategy. And whole genome sequencing may find you another sort of 10% that you had missed, but most of the time it's pretty hard to interpret still at this point. One of the places that I think a lot of this excitement is happening is this network of centers now funded by NIH across the country that is looking at undiagnosed diseases, where people who have had the experience, many of them for 4, 5, 6, 7 years, of having a very puzzling set of medical problems that nobody could make sense of, come in for a complete evaluation, all kinds of phenotype information, and complete genome sequencing. And we're now doing pretty well. Something like 40% of those individuals turn out to have an answer. And out of that has also come the new description of more than 24 disorders we didn't know about before, but now we have detailed answers to. And for a few of them, a very clear indication about a different therapeutic approach that's provided benefit. So a long answer, but I think exome sequencing at the moment, fantastic opportunity, ought to be applied wherever we can figure out a way to do it. As the cost continues to drop for whole genome sequencing, which is now under $1,000 and which people are saying will get to $100 in the next 5 or 10 years, then why would you do exome sequencing anymore? Because you want the whole thing. However, data science people, that means you're going to have to deal with even more petabytes and more information you have to sift through to see what it means.
One of the few advantages of actually sitting in this seat is I get to interrupt and ask questions myself. And it made me, as you were answering that, it made me think about the whole rare disease community and how those communities sort of come together to create a cohort when it's clearly, because it's rare, that it's not that big, and that's so critical. And it's sort of, they're motivated to participate because of their conditions. But what we also see is often motivation in areas and within people who are not necessarily trained in these areas, but often make these kinds of contributions. And the NIH has tried to drive some of that forward with competitions, and I know, I'm not sure about the situation in the current government, but in the previous government there was certainly a push to open up these competitions to enable more people to actually participate in various ways, in this case, in potentially in healthcare. Is that something that you feel that is oversold, or it could be expanded, or how do you feel about that?
Oh, I don't think it's possible to oversell it. I think we are at the point where people are much more interested than maybe they were 20 years ago in the possibility of taking part in medical research, but they do not expect to be treated like human subjects and basically told nothing about what happened. They want to be participants, they want to be at the table, they want to help decide what's going to happen to the data, who gets access to it, and most of the time they want as many bright minds as possible to look at it. Certainly with all of us, this million-strong program, the participants are very much telling us what they want to be done with the data, and they are very much telling us what they want to learn about themselves, including some of them want to see their complete genome sequence. Even though we can't interpret it, they want to see it just to see that it's there, and I think that should be honored. And some are a little shocked by the idea that we would be delivering such data to participants, but I think we've arrived at the point where that's the right thing to do.